The study was titled Possible Serious Bacterial Infection, and as the name implies, we were testing newer methods of treating PSBI, which are more away from the hospital and more closer to home. What's going on? All right. So this is a roadmap for my presentation, regular. I'll go through the background, the objectives, participants, and results. I think Dr. Qazi elaborately explained that we had the 2015 guideline for managing PSBI in babies where referral is not feasible. And I just want to say that the baby that you see, and we are all familiar with this picture because anybody who works in the area of PSBI, this is the flagship photo of the PSBI guidelines where referral is not feasible. So this baby is now 10 years old almost, and the proud grandparents are actually in the audience. So Dr. Qazi and Dr. Zaitoon Qazi. Yeah. Fast forward to 2021, Dr. Qazi did mention this as well, when all of the data was put together and we looked at how these babies are doing at first level facilities. What was noticed was that there were some babies when they were managed outpatient, especially the ones who had only a single sign, and these are what we call as the single low mortality risk sign. We saw that there was very low mortality in those babies. So I'm not sure whether it's projecting well, but you can see on this side of the panel that some of these signs like fast breathing, high body temperature, we saw very low mortality rates and the death rates were very low. Then there were some infants who were presenting with these PSBI signs where the risk was medium or moderate. And actually it was thought that maybe these babies just need a few days of hospitalization because the risk of death again is not too high. It's not too low, but also not too high. So for example, symptoms like moving only when stimulated, stopped feeding well, low body temperature, the mortality was relatively higher, but still lower than what we saw with critical illness, where the case fatality rate was, the mean case fatality rate was 16.9, but it was as high as 27%. So in 2022, two multi-center individually randomized open label trials were conducted across 7 sites in 6 countries. And this is the trial that we are here to discuss today. This picture is actually showing all the countries where the studies were done. And in Asia, in South Asia, the study was conducted in 4 sites and 3 countries, and also 3 countries in Africa. And all of these countries participated in both the RCT1, which is the single low mortality risk sign study, and RCT2, which is the moderate mortality risk sign study. And Pakistan contributed to about 2,000 babies cumulatively to the 2 trials. So now I'm going to jump to what the trials were about and the results. Almost all of our investigator team is currently in the audience, and this was a huge teamwork which led us to getting ethical approvals for the proposal, designing how we will implement it, and then actually implementing it on the ground. So RCT1. As you can see, RCT1 is related to the single low mortality risk sign trial. Here the question was whether outpatient treatment compared with inpatient treatment in babies who are 0 to 59 days old, if only one low mortality risk sign of PSBI, if these babies treated in the outpatient, whether the treatment was better or at least non-inferior, which means that it was not worse than what it is in inpatient. And what were the outcomes we were interested in? So we studied the outcome of death, presence of critical illness or another serious infection, presence of any new sign of PSBI or persistence of the presenting signs. The treatment that we gave for the babies who were admitted, we gave them inpatient antibiotic IV for 7 days, and this was injectable ampicillin plus gentamicin. Ampicillin was given 3 to 4 times daily, while gentamicin was given once daily, along with other supportive care. In the outpatient arm, the babies were given 2 doses of gentamicin once daily. This was the injectable component, and 7 days of oral amoxicillin, which was given twice daily. So in this trial, the babies were immediately triaged. So who were eligible in this? As I mentioned, they are babies who are 0 to 59 days and who have one or single low mortality risk sign. What are those signs? Those signs were fever more than or equal to 38 degrees, having severe chest indrawing, or fast breathing. So only one of these signs would be present. They would be eligible to participate in this trial. This is a very elaborate flow. I will just very quickly take you through it. So it was imperative that these are babies who are just walking into the emergency with their families and they are self-presenting. They would register at the desk in the hospitals, and then they would be triaged. At this point, the triage would be done entirely by the hospital staff. Then at this time at triage, it would be determined how sick they are, whether they have one sign or multiple signs, or they have critical illness. If they had critical illness, they were immediately sent for resuscitation and further management. But if they had a single low mortality risk sign or any moderate mortality risk sign, they would be referred to the study physician, who would then again do the screening to confirm that the signs that have been picked up by the study hospital staff are actually in agreement. So the two people had to agree that the sign was present before they got the screening consent and the randomization. So important to note is that very critical steps in identifying whether this baby was fairly eligible for the trial was actually done by the system itself and not by the researchers. Okay. So this is a summary of RCT1. Again, we actually looked at about 30,971 babies looking for signs of PSBI. And we had 1,566 who were eligible for RCT1, 1,680 who could be eligible for RCT2, and about 8% who had critical illness. So I'm currently going to talk about RCT1. Of the 1,566 with single low mortality risk signs, 1,125 consented, and almost half and half were randomized to the inpatient and the outpatient arm. The outcome that we were looking at was called poor clinical outcome, and this was defined as deaths, critical illnesses, presence of any new sign, or persistence of presenting sign. As it is clear, in the inpatient arm, there were 48 out of 564 who had a poor clinical outcome. In the outpatient arm, it was 31 out of 561. Importantly, the deaths in the inpatient arm were slightly higher than the deaths in the outpatient arm. There was slightly higher critical illness seen, but these were appropriately managed. In the inpatient arms, slightly more number babies developed a new sign, and there were many who had the persistence of the presenting sign. Now RCT2. So RCT2 is related to the moderate mortality risk signs. The question we were asking in RCT2 is, among these babies who have this moderate mortality risk sign of PSBI, can we discharge them early by switching the IV antibiotic to an oral treatment and complete their oral therapy at home after 2 days of hospitalization? And the question we were asking was whether this switching and sending home is not worse, or we can say it's almost similar to continuing IV antibiotics in the hospital. Here, the outcomes again were death, critical illness, presence of any new sign, and persistence of the presenting sign. In the inpatient arm, the babies were receiving 7 days of injectable antibiotics, ampicillin plus gentamicin, along with other supportive care, while in the outpatient arm, the treatment with injectable gentamicin, which was given once daily for 2 days, plus oral amoxicillin twice daily for 5 days. So in the outpatient arm, the babies had already received 2 days of injectable antibiotic in the hospital before being discharged. Eligibility was young infants. The moderate mortality risk signs we were looking at were baby who has stopped feeding well, who is lethargic, not moving, only on stimulation, who has a low body temperature, or has 2 or more signs of the low mortality risk signs. So those babies were considered moderately ill, and then they were all admitted into the hospital. 48 hours after admission, they were examined for their clinical status. If they were well at that time, they had no critical illness, they had no signs, plus they had a test. So we had introduced a test here, the CRP. So if the CRP was negative, the baby was clinical well, and he was in the arm that receives outpatient treatment, they were discharged. This is again a repeat of the flow, but very similar to what we did in study 1, where the focus again. So I think important to show here is that this decision of reassessment was done in tandem between the hospital and study physician, and we had to have agreement from the hospital physician. This is a summary of the results. So this is the same full cohort that we were studying. So now you can see in the middle, it's RCT2. So moderate mortality risk sign babies, there were 1,680, out of which 799 were consented and they enrolled after assessing complete eligibility. In the inpatient arm, there were 399 babies. In the outpatient arm, there were 400 babies, and we looked at clinical outcomes. The number of clinical outcomes in both the arms was fairly similar. The number of deaths were slightly different. There was not a single death in the outpatient arm, but there were 2 in the inpatient arm. There was 1 critical illness in the inpatient arm, none in the outpatient arm. And in the outpatient arm, a very slightly high number of presence of any sign of CSI was seen. Of course, these babies were also appropriately seen and managed. I just want to say that, the main importance of CRP in RCT2 was that we were using it to decide whether to send the baby home. In Pakistan side, and Pakistan is only one side that did blood cultures as well for PSBI, because we thought that this is important information that we can give to our pediatricians, neonatologists, and our AMR specialists. So what we used here is this bedside CRP kit, and it was implemented right on the side of the bed by the nurse, and the decision to discharge or not was taken within 5 minutes of doing the test. This is just showing you the distribution of CRP positivity. So in RCT1 babies who were all enrolled and in whom we did CRP, we did it in 1,069, and in these babies we did serum CRP. So the positivity was just 13%, while in RCT2 we did a total of 1,162 CRPs, because we were checking whether CRP is normal before discharging them, and here the positivity rate was slightly higher, it was 18%. This is showing you the blood culture positivity in the RCT1 and RCT2. So in RCT1 with the low mortality risk signs, the positivity of blood culture was only 1.5%. And these cultures were all done in the hospitals and transported to the laboratory at Aga Khan University where they were cultured. So the positivity was just 1.5%. For babies who were moderately sick, there were some who got enrolled and some were not eligible because they were not getting better. So at 48 hours, among the ones who were enrolled, the blood culture positivity rate was 3%. So double what was that in RCT1, but still considerably low. When we look at the non-enrolled, which were the babies who were sick or who had a positive CRP, the culture positivity rate is 10.5, 10.8, almost 11%. It is much higher and it is anticipated actually. So it really showed that our CRP was, detecting like illness and sickness, and it was screening out the babies who will not qualify for an further outpatient treatment. This is just distribution of the blood culture positivity by organism. No surprises there. Majority were gram-negative infections, some gram-positive, and here we tried to remove contaminants as much as possible, and very little yeast infection. There was quality control, that's needless to say. We also did cost analysis, and this was for the entire study as well as Pakistan specific. So what you see here is that the total cost per case for treatment of a baby in RCT1 was 18,000 rupees. While somebody was bearing the cost, obviously, although most of these hospitals were providing free treatment, while the treatment cost in outpatient was just 2,000 rupees. And if you break down these costs by what was spent by the facility and what was spent at the household level, you can see that majority of the costs were at facility level, but there were considerable costs at the household level. So they were obviously very high with the inpatient treatment, but very low in the outpatient treatment. When we look at the cost of treatment in RCT2, again, you can see here that there is a difference between completely inpatient treatment versus the switching antibiotic and outpatient treatment. So the cost was 26,000 rupees for inpatient management of moderately sick babies, while in the outpatient it was 14,000. And if you look at these costs, again, majority of them were facility costs, but significant cost at the household level as well, and significantly reduced cost when baby was being discharged early and sent home. So what we see here is for the low risk sign studies, outpatient treatment is like treating the baby inside the hospital for 7 days. In the outpatient arm, we saw that the worsening did not happen as much as we saw in the inpatient arm. And overall, the good thing was that most babies took almost all their doses, but the compliance was actually better in the babies who were managed at home. When we look at the moderate risk trials, the RCT2, we saw that switching to oral antibiotic therapy at home after 48-hour hospital admission with injectable antibiotics is like a 7-day course of injectable antibiotics in the hospital. And using the CRP just before discharge helps us making that decision with more confidence. Overall, 96% of the babies in this trial received all of their antibiotic doses, so there was no problem there. And there was no increased worsening in the babies who were managed at home, and more importantly, there were no deaths. Thank you for listening, and I'm just going to take a minute to give a shout out to our stellar PSBI team. Can I ask everybody who was involved with the PSBI trial to please stand up so that we can give you a round of applause. So it literally takes a village. Thank you so much. Thank you to you, Dr. Jamal, as well. And if you can't see their faces, so these are the two, our team leads for the trial, the physicians of the different hospitals. We have the AKHMC Kharadar, we have NICH, we have SICHN, and then we have Sindh Government Children's Hospital in North Nazimabad. These are other team members within the different hospitals. We had a big data management team, the infectious disease research lab team, a few pictures from the trial that I thought would be nice because we should be doing some appreciation as well, activities that we had in this time. There were a lot of refresher trainings to ensure that, you know, the physicians and the people who were involved in the trial were up to the IMNCI guidelines, as well as identifying sick babies. And yes, we needed this respite very much because I must say that it was an extremely challenging study. And it would not have been possible without the leadership of the hospitals, and all the leaders are present here today who were leading the trial as co-investigators, and their very, very dedicated teams. And, you know, we did this retreat just to get rid of some steam. This is a little video that the team has put up, so I'll just run it for a minute and then. Thank you.